1 and go.
Hi everyone, this is Deb back, and I am so thrilled to be able to bring you back to have Dr. Rachel Gafni come and finish her talk on updates with the clinical trials at NIH. So Dr. Gafni, if you'd like to take it over, welcome aboard.
Great, thanks so much, Deb, and I'm really sorry about the technical difficulties yesterday. I think NIH internet was having some trouble with the Teams stream, so today I'm streaming from my house, so hopefully that will work better. I'm not going to repeat everything I said yesterday. Hopefully most of you were on the talk and were able to get that, but I'm gonna jump ahead just to remind everybody that I was talking about, I'm skipping all of these slides, but just to remind you, we were talking about the calcium sensing receptor and how it's critical for controlling the sensation of calcium in the blood and controlling the release of parathyroid hormone and also the kidney's response to calcium levels in the blood. And we were talking about autosomal dominant hypoparathyroidism, and in this case, I'm just going to skip ahead to this slide. This autosomal dominant hypocalcemia type 1 or ADH1, where the calcium sensing receptor is stuck in the activated state and tricking the body into thinking that the blood level of calcium is higher than it actually is. And again, that's as if you set your thermostat at 70 and it's really, really cold in the room and you feel really cold, but for some reason the thermostat is telling your furnace that it's really 80 degrees and your furnace just won't turn on. So the blood calcium is low, and the calcium sensing receptor is telling the parathyroid that the blood calcium level is high, and so you're not making parathyroid hormone. And the same thing in the kidney, it's telling the kidney that the calcium level is high even when the calcium level is low, and so you lose calcium in the urine rather than keeping it in the blood. We talked about the signs and symptoms of ADH1, which are very similar to other forms of hypoparathyroidism. And we were talking about what it means to be an autosomal dominant disorder. And I mentioned that the gene for the calcium sensing receptor is on chromosome or autosome number 3. Autosomal dominant disorders are passed directly from parent to child. There's a 50-50 chance of passing it to a child with every single pregnancy. And that it's not uncommon for someone to be the first person in the family with ADH1. But once you have it, you can continue to pass it to your children, and your children can pass it to their grandchildren, again, with a 50-50 chance in every pregnancy. Now you might wonder, I keep saying ADH1, so is there an ADH2? And yes, there is, and this disorder is even rarer than ADH1, and it's due also to an activating change of a gene, but it's a different gene. It's a gene that's what we call downstream from the calcium sensing receptor. So it basically does the same thing. It tricks the parathyroid cell into thinking the blood calcium level is higher than it actually is and prevents parathyroid hormone production. So here's pretty much where we left off yesterday. How do we manage ADH1? And it's very, very similar to other forms of hypoparathyroidism, and you're all very familiar with this. We have calcium in multiple divided doses per day. We use vitamin D, either high dose regular vitamin D or calcitriol. Sometimes these patients are treated with magnesium because they can have very low magnesium levels, and sometimes thiazides as well to help with the urine calcium excess. It's interesting to note that parathyroid hormone is sometimes used in these patients, but they were completely excluded from participation in the studies on parathyroid hormone that led to the approval. So we don't have as much data of using PTH in people with ADH1.
Dr.
So current treatments are inadequate. Yes.
I'm not sure if you can.
Are you losing my sound again?
Yes. So maybe if you turn off your presentation and just use your microphone. It says turn off your video and just use your mic.
Turn off my headset. Is that what you're telling me to do?
Turn off your presentation.
Hey, I'm sorry, Rachel, just go ahead and turn off your video. No, just your video.
Can you hear me now?
Speak.
Okay. Can you guys hear me? I'm not sure what you were asking me to turn off my presentation is what I heard.
I don't.
Hello?
All right. Speak loud.
Is anybody out there? Is anybody hearing me?
Yeah. Hey,
Somebody
Rachel.
write something in the chat. Okay. Can you hear me now?
Yes, ma'am, we can.
Okay,
Yeah.
so you want me to talk without showing any slides? Is that right?
No, we want you to present your slides and just turn off your video.
Ah, turn off my video. Okay, sorry, I couldn't hear you. So
Nope, I completely understand.
okay, let me reconnect my headset and turn off. I'm going to turn off my video, and I'm going to reconnect my headset, and I'm going to share again, and I'm going to thank everybody for their incredible patience with this. I'm going to return. Just going to use. You hear me?
Yes.
Okay, I am putting back on my shared slides, and I'm going to go back to this where.
That sounds so much better already.
Yeah, is that better? Hopefully
It
better.
is.
Okay, so we were talking about current treatments are inadequate. We target blood calcium below the normal range, but of course, patients still have symptoms of low calcium. And the treatment can worsen hypercalciuria and renal calcifications, which can lead to impaired renal function. So really what we need here is precision medicine to possibly target the abnormality in the calcium sensing receptor. And so we could try to do that with a class of drugs called calcilytics. So what is a calcilytic? They are a class of drugs that turn down the calcium sensing receptor. So they kind of fix the broken thermostat, if you will. They make the parathyroids and the kidneys more sensitive to the blood calcium level. And this results in increased PTH secretion and less lost calcium in the urine. And this class of drugs was developed as a potential therapy for osteoporosis with the thinking that instead of, PTH is approved as a treatment for osteoporosis, and it's given as a daily injection. And so the thinking was, well, instead of giving people a shot of PTH, maybe we could give them a pill, a calcilytic, that would cause their own PTH levels to go up, and that would help with their osteoporosis. But what they found in the studies, and they've treated over 1,000 women with a couple of different types of calcilytics, and they found that it caused them to have an increase in blood calcium and PTH, but it didn't actually help with their osteoporosis. So the drug was not pursued, or this class of drugs was somewhat abandoned as a treatment for osteoporosis. But we're lucky because we have a lot of safety information in people who have normally functioning parathyroid glands. And the safety profile was very good in these patients. So this is a repurposing of existing drugs. So just to reiterate, calcilytics turn down the calcium sensing receptor. So here we have a parathyroid cell with a change in the calcium sensing receptor that's preventing parathyroid hormone release, even though the blood calcium is low. And then we add this calcilytic on top of it. And as a result, PTH starts to be made and then released into the bloodstream, and that increases the blood levels of calcium. Similarly, the addition of the calcilytic would also help the kidney understand better what the actual calcium level is, and it would decrease the calcium level in the urine. And so what we know so far is that there are animal models of ADH1 that have been treated with calcilytics that have had improvement in blood calcium and decreases in urine calcium. So really, this is the perfect opportunity to now bring this to this patient population. And back in 2014, 2015, we did a small pilot study, which I presented to this group a couple of years ago. We looked at 5 patients with ADH1 and we gave them daily infusions for 5 days of this calcilytic called SHP 635 in increasing doses. And we had these questions: will their PTH levels go up? Will their blood calcium levels go up? And will their urine calcium levels go down? And what we saw in this very small study was that, yes, at the highest doses, we did see an increase in the parathyroid hormone level. You can see it going up over time. But as soon as we stopped the infusion at 200 minutes, the PTH level went back down. This was such a short exposure that it didn't translate into a change in blood calcium. But we did start to see the suggestion of a decrease in urine calcium while they were receiving the infusion. So we needed to look to the next step. We needed to give higher doses for a longer duration, and we wanted to give this as a pill, not as an IV medication. So that brings us to our current study, which I'm going to mention briefly, and it's got a really, really long name. It's a phase 2b study, dose ranging study, evaluating safety and tolerability and pharmacodynamics and pharmacokinetics, to look at this other calcilytic called CLTX-305, specifically in patients who have ADH1. And here I have listed the clinicaltrials.gov number. And so there's a whole list of eligibility criteria to be in this study. Most of them are pretty easy to get through. I'm not going to go into them in detail right now because of our limited time today. But I will give you contact information at the end. And certainly if you think you might be interested in participating in this study, you can contact us and we can go through your eligibility criteria. We can't take patients who are currently on parathyroid hormone. So if you are on your parathyroid hormone, you need to be off of it for at least 3 months before entering into this study. The study involves several periods. The first visit is a screening visit where you would stay overnight at the NIH to assess your eligibility, and we'd do blood work and a urine collection and some imaging studies of the kidneys and the skeleton. And then if you're eligible, you would come back either for period 1 and 2 or just period 2. Both period 1 and period 2 are 1-week intensive visits where you stay at the NIH the entire week, sleeping over in the hospital, and you're given different doses of the drug CLTX-305 once or twice a day over the course of 5 days. And during that time, we draw blood and collect your urine multiple times a day. It's very intensive. But to minimize the number of needle sticks, we either place IVs or a peripherally inserted central line to draw the blood from that. So even if we're sampling you 18 times a day, drawing your blood, we're not poking you 18 times a day. And you have to also collect your urine continuously. So it's a bit it's a bit of a commitment, but we find that our patients with this condition are really, really motivated to try to make things better for them, their children, their grandchildren, and other people that they don't know as well, because this is a difficult condition to manage, as many of you know. So period 2 is similar to period 1. It's just it's further along in the dosing interval, in the where we're trying to still work out the regimen. So the purpose of period 1 and period 2 is to figure out the best dose and how frequently to give it, once a day or twice a day. Some patients will do both period 1 and period 2, and some patients will just start straight into period 2, depending on how far along we are into the study. At the end of period 2, though, you would go home on the treatment and continue taking it at home for 24 weeks and come back 3 times every 8 weeks for brief visits to the NIH, again, doing that frequent blood and urine sampling. So it takes, from start to finish, if you were to do the entire study, it would take about a year, maybe a little bit less, depending on how close together period 1 and period 2 are. But I will tell you that we've already started the study and have several patients already in period 1.
So the main goals of the study are to assess the safety of the drug, to determine the best dose that will increase and stabilize the PTH, increase and stabilize the blood calcium, decrease the urinary calcium, decrease and stabilize the blood phosphorus, and increase and stabilize the blood magnesium. So what are the risks in monitoring? Well, the main risk of the drug is increased calcium and PTH, which is what they saw in the osteoporosis population, but this is a desired effect for us, so we're capitalizing on that. Of course, if the drug doesn't work, then patients could have hypocalcemia, but we're monitoring the patients so frequently, and our nurses are really excellent and very comfortable with hypocalcemia. We do give supplements, of course, if dietary calcium is less than 1,000 milligrams a day, but really there haven't been identified specific safety signals or adverse events in the osteoporosis studies. All visits take place at the National Institutes of Health in Bethesda, Maryland, and we do provide your travel. So we would pay for your airfare or reimburse you mileage or your train fare to come to and from the NIH. And in addition, because it is such a difficult study and inconvenience, and you have to take off time from work, although now everybody's teleworking, so why not do that from a hospital bed at the NIH? Patients are compensated up to $850 for each period completed. So if you do the entire study, you would get a maximum of $2,550, which really is our way of trying to help offset the burden of coming to NIH. For more information, again, this is our clinicaltrials.gov number, and this is the name of our investigators. Karen Pozo is our research nurse and study coordinator. She's amazing and always available to talk to you. Iris Hartley is one of our lead associate investigators who's very involved in the study, and of course, my contact information. But wait, there's more happening at the NIH, and I'm just gonna mention very briefly a study that's being done by some other investigators on the disorder called APSED, autoimmune polyendocrinopathy, candidiasis ectodermal dystrophy syndrome. It's also called APS1, or autoimmune polyglandular syndrome type 1. And in contrast to ADH1, this is an autosomal recessive disorder, which means that both parents are carriers and you need to have 2 copies of the changed gene to have this condition. So there's a 25% chance of having APSED with each pregnancy as compared with a 50% chance with each pregnancy in ADH1. And the thing about this condition is this is part of a greater syndrome because inactivation of this gene called the ARI gene causes many autoimmune disorders. And I'm sure you're talking about this in another session. So I'm not going to go into it in detail, but this is a list of some of the many autoimmune conditions that can be associated with APSED, in particular hypoparathyroidism, adrenal insufficiency, and fungal infections in the intestinal tract. Patients also can have enamel hypoplasia, and they can lose their hair and sometimes get hives, which can often be a very early sign. This is some of the skin and nail features that we've seen in some of our patients. So there is an APSED study going on at NIH that's actually conducted in the Allergy and Immunology Institute. And the principal investigator is Dr. Michalis Leonakis. They've enrolled 150 patients so far since 2013, which is the largest cohort in the world. And they've become very, very experienced. And they're really looking at it from a very global perspective to analyze the autoimmune process, because of course it's not just hypoparathyroidism. There are so many other autoimmune conditions associated with it that really trying to target the autoimmune disease is the focus of this group. Patients come from all over the world. They stay for a week at the NIH and have a very comprehensive evaluation. There's no cost to the patients, but you do have to pay for your own travel for the first visit. Subsequent visits would be paid for by the NIH, and you receive all of your results, and your physicians will as well. And this is to better understand this disorder. Patients with APSED who enroll in this study are enrolling in a larger study called the Fungi Research Study, because there's patients with other causes, other fungal conditions that are also enrolled in the same study. But this is a really great opportunity to participate in clinical research, receive expert, excellent care at the NIH if you or one of your loved ones has this condition. And again, the contact information for these investigators is listed below. And I'm just going to conclude now and take some questions. Calcium sensing receptor plays a key role in regulating parathyroid hormone production and renal calcium handling. Activating changes in the calcium sensing receptor cause ADH1. Calcilytics are drugs that turn down the calcium sensing receptor and hold promise as an oral therapy for patients with ADH1. And APESED is another rare genetic cause that can affect many organ systems. And research into both conditions is very active at the NIH, and we're working hard to try to find better treatments. Of course, I'm a pediatrician, as some of you may know, and a lot of these studies, not the APESED study, but the calcium sensing receptor study that we're doing right now is limited to patients 16 and older, but we do need rigorous pediatric trials. So the more we are able to conduct this research, the more likely we are, if we see good results, that we're able to hopefully do pediatric trials as well in the future, but not at present. This is our group at the NIH and some other areas that groups that have participated with us in research in the past. And of course, our current study is being sponsored by Calcilytics. So I'm happy to take any questions now. I will stop sharing my screen and maybe put my video back on. And hopefully that will still work. I think we have maybe 4 minutes for questions.
Okay, first question. Do you think calcilytics is safe for pregnancy and breastfeeding?
You know, I really couldn't speak to that because I don't think it's been studied in pregnant or breastfeeding individuals. Remember that this class of drugs was developed as a treatment for postmenopausal osteoporosis. So the vast majority of patients who've been exposed to this class of drug have been postmenopausal women who couldn't even get pregnant. But I think these are great questions, and hopefully if this drug proves to be effective for ADH1, there will be future studies that could include pregnant and or breastfeeding individuals.
Okay, another question. After the initial evaluation via phone, when is the screening visit period 1 scheduled?
So it just depends on our availability. Right now, we're pretty much scheduled up through January. So we wouldn't be necessarily bringing anybody for a screening visit at this point, probably until February. But, you know, we would work with your schedule to try to make it possible. There are some patients who will only do a screening visit and then period 2 and period 3, and then other patients who will also do period 1. But most of the patients who are doing period 1 have already been identified and are getting started right now.
Okay, I've got quite a few questions asking why are you basically dealing with ADH1 and not surgical?
Yeah, that's a great question. So I don't think we know right now if this drug might be a possible therapy for post-surgical hypoparathyroidism. Right now, this drug is really targeting the calcium sensing receptor, which we know is not functioning properly in patients with ADH1. So our hope is that we can increase parathyroid hormone secretion in addition to having an effect at the kidney. Using this drug in post-surgical patients might have an effect at the kidney, but it won't increase parathyroid hormone secretion if the parathyroids have been removed. But there may be some benefit by just increasing calcium reabsorption and decreasing urinary calcium. So I think that it's a great question, and it definitely is one that should be considered for future research.
Question, any studies being done for those with pseudo-hypoparathyroidism?
So there is a group that we work with an investigator named Dr. Lee Weinstein, who studies pseudo-hypoparathyroidism, but I'm not aware of any treatment trials that that they're doing for that condition. It's it's more diagnostic evaluation and genetic testing related studies, but not treatment trials. I know that there have been some studies, not specifically for the hypoparathyroidism, but using growth hormone and other things for other parts of pseudohypoparathyroidism besides the actual hypoparathyroidism.
Okay, good question here. How would a patient go about getting tested for these conditions?
That's a great question. So getting genetic testing for changes in the calcium sensing receptor is very easy and available. The biggest difficulty is really trying to see if your insurance will cover that. So if you work with your endocrinologist and you want to get tested for it, there are many different genetics labs around the country that do it. And but you just need to talk to your doctor, and they might need to find out from your insurance company and get prior authorization for that.
Well,
and the same for APSED for the ARI mutations. It's easy. There's lots of labs that do it, but insurance is sometimes the stumbling block.
Well, last one is not a question, but it's a thank you for your research. It gives me and my daughter great hope for our family.
Yeah, we're really excited. We've been talking about these calcilytic studies for many, many years, and there was a big gap between the last study and this one. So we're so excited that things are moving forward and there's so much interest in the study. And thank you so much for inviting me. And next time, well, I hope I'll see you all in person.
Amen to that. Thank you very much, Dr. Gafni.
All right. Take care, everybody.
Bye-bye.
Bye-bye.